Hello and welcome to our NYU Langone Orthopedics webinar focusing on hand surgery, wrist pain, evaluation, and treatment. Thank you for joining us. My name is Tyler and I will be the facilitator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you will see the Q&A window. To send a question, click in the text box and type your text. When finished, click the send button or press enter. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed throughout and at the end of the presentation. With that said, I will turn it over to our introductory speaker, that is Dr. Catalano. Doctor?
Welcome, everybody. I'm going to introduce our agenda here and everybody, and then we're going to start. Welcome to the NYU webinar titled Wrist Pain, Evaluation, and Treatment. We have 5 speakers. We're each going to speak about 12 to 13 minutes, and then we're going to get some questions after each speaker, and then we'll go over some questions at the end for the last 10 to 15 minutes. The first speaker is going to be Dr. Jacques Hacquebord, and he's going to talk on examination and imaging of the painful wrist. Next will be Dr. Stephen Yang, wrist arthritis, patterns, progression, and management. Then I'm going to speak about the TFCC Tears and Ulno-carpal Impaction. Dr. Paksima is going to speak on common tendinopathy about the wrist. And then our wonderful hand therapist, Olga Hincapie, is going to speak on she's going to talk on hand therapy innovation interventions for wrist pain.
Hey, Dr. Catalano, I'm so sorry to interrupt you. Just a quick moment. Your voice is breaking up a little bit. Do you mind possibly either putting it to speaker or taking it off of speaker, just whichever one it isn't, to see if we can get that voice to stop chopping up?
I'm not on speaker. Is that okay or not?
Sure. It's still chopping up a little bit. If you could finish it up, and we'll let you know if it gets to the point where you may have to hang up and call back in. But continue on for now. Oh, and it looks like we just dropped Dr. Catalano, so if everyone can give us just one moment, he should be joining back in with us within about 5 to 10 seconds. And again, just as a reminder, for anyone that wants to ask a question in the Q&A box, you can do so at any time. You'll just need to type into that Q&A box on the right-hand side and press the send button or enter. We'll pause for just a few more moments while we get Dr. Catalano back in with us.
Hi, this is Dr. Paksima. Dr. Catalano is having some phone difficulties, but we can go ahead and get started with our first speaker.
All right. So I'm Jacques Hacquebord, and Dr. Catalano, wherever you may be, thank you for the introduction. So I'll be speaking on the examination of and imaging of the painful wrist. Of course, this is a topic that we can spend a lot of time on. I'll try not to do that and bore you, but I think the most important thing is that when you examine anything, you have to know the anatomy. And with the hand, the anatomy is so superficial; it's just underneath the skin. But it's a very complex anatomy. And so when you look at the hand, you have to have an idea of what are the underlying structures, what are you looking at. And knowing the surface anatomy is very important. Some landmarks on the dorsum of the hand is Lister's tubercle. I find Lister's tubercle to be very, very important because it gives you an idea of where the tendons are, the various compartments, where the dorsal rim of the distal radius is, where the scapholunate interval is, and on the volar surface, the hook of the hamate, the pisiform, and the distal pole of the scaphoid are also very helpful in sites of certain pathology, but also good to orient you. So it's always important to know what you're looking at. Now, when you look at schematics of the wrist, this can be incredibly intimidating what you're looking at and very complex. But one of the things that I'd like for you to take away from tonight is that the proximal carpal row, the scaphoid lunate triquetrum, functions like an intercalated segment. So it sits between the distal carpal row, which is basically the hand, and the radius and the ulna, which is basically the forearm. and it moves not independently, but it moves as its own segment in between those two anatomical pieces. The volar carpal ligaments serve as guide wires and struts to help it to continue to move. And if you look at the wrist also, you move your wrist around, your wrist almost has a complete circumduction. It's almost functioning like a ball and socket joint, which is really incredible if you look at all the little bones and that the wrist can move like that. But it's important to know that motion, that cumulative circumduction that you have in your wrist is coming from an aggregate of numerous intercarpal joints that are moving all a little bit that allow for that motion. Another important thing to take away from tonight is people often talk about carpal instability, but the wrist actually has a tremendous amount of potential energy stored in it, and its normal physiologic state. And so when certain ligaments are injured, then there's what we oftentimes term as instability patterns. However, what it really is that the wrist is in an unstable position physiologically, and once those ligaments are injured, then the wrist goes to actually what is a more stable pattern, which is pathologic. So we talk about instability, but it's actually a misnomer that the wrist is in an unstable position physiologically, but when ligaments are injured, it goes into an it goes into a stable but pathologic pattern, which we term as instability, but actually is more stable. And this is an example of a scapholunate injury where there's a typical pattern of the scaphoid and the lunate. Now, the scaphoid wants to flex, and the lunate wants to extend, and that's the normal physiologic state. And once that scapholunate ligament is injured, this is just an example, then it falls into the predictable pattern of instability, which we call instability, but it's actually more stable. Hopefully that wasn't confusing. I'll just touch on it very briefly, are the ligaments of the wrist. Very complex, and it's out of the scope of this talk, but it's important to know that there's the dorsal and the volar ligaments, the intrinsics and the extrinsics. The vasculature, you have the radial and the ulnar artery, the predominant sources. The radial artery is providing flow into the deep palmar arch, and the ulnar is the superficial palmar arch. And the normal in most wrists, there's good collateralization between all those, and there's a complete flow through the radial into the ulnar through the deep and superficial palmar arch. Dorsally, you have arteries that are relevant for various treatment options for scaphoid non-unions, Keenbox, and so forth, 1, 2, ICSRA, and the 4th and 5th, ECA. And then the distal ulnar joint, very briefly, is a very complex joint. It's inherently actually an unstable joint, and so there's a significant soft tissue construct, the triangular fibrocartilage complex, that holds it reduced and stabilizes, which is otherwise an inherently unstable joint. And I think Dr. Catalano will be talking about it in greater length. It's just important to remember that the radius rotates around the ulna, specifically around the fovea of the ulna. So when you're looking at your wrist, what's rotating around what? The ulna is remaining motionless, and the radius is rotating around it. And then the ligament disattachments, very briefly, that help stabilize that are the palmar radial ulnar ligament and the dorsal radial ulnar ligament that attach in two spots. The deep attaches to the fovea, and the superficial attaches to the ulnar styloid. Now, the ECU has its own attachment that originates from the dorsal radial ulnar ligaments, which help to stabilize the DRUJ as well. Now, on examination of the wrist, first and foremost, the patient history, for me, is incredibly important. You have to get the patient history because that's going to, the majority of the time, going to give you a strong indication of what's going on. When did the patient injure it? How did they injure it? What activity were they doing? How often does it hurt when they do that activity? For instance, if someone says, I hurt my wrist when I was doing something at the gym, it's really important to know exactly what activity was it doing. What were you doing? Were you doing front squat? Were you doing snatches? What position was your wrist in? And what activities now reproduce that pain? So the patient history for the wrist is incredibly, incredibly important. I can't overstate that enough. And then, of course, looking at the range of motion, flexion, extension, ulnar deviation, radial deviation, and dart throws motion. Where is it tender? Palpation, because that anatomy is relatively superficial. Palpation is incredibly important. And then when you palpate anything, to know what are you palpating. Is it the scapholunate interval that you're palpating? Is it the pisiform that you're palpating? Is it the hook of the hamate? And on which side of the wrist is it painful? And of course, sensation vascularity is very important. Now, there are numerous special tests, provocative maneuvers of the wrist, and we're not going to go through all of them because there are too many of them. And every few months, there's a new provocative maneuver that's described by someone somewhere. The important thing, in my opinion, is to know some of the key provocative maneuvers, and then also to know how they're categorized. What are they looking at? So scapholunate pathology is a very common thing that we look at, and I'm not going to go into detail about that. But tenderness is very important, tenderness over the scapholunate joint. But that's a non-specific finding because there are many other things that it could be. It could be static or pre-dynamic SL pathology. Obviously, that's what you're looking for, or an occult dorsal ganglion, or scaphoid impaction, or dorsal carpal impingement. So it gives you an idea, but once again, it doesn't diagnose it for you. The Watson shift test is also something that we use for scapholunate pathology, but that also can be a difficult test to perform. And then you also have to compare it to the contralateral side, because someone may have what you determine to be an abnormal Watson shift test, but then you examine the other side and you realize, you know what, that seems to be very, very similar to the contralateral side. Lunotriquetral pathology, I apologize for the misspelling of pathology. There are several tests designed for that as well. And of course, you can look at videos and learn about exactly what those tests are. But one of the things about lunotriquetral pathology is that, to be honest, I haven't seen that much lunotriquetral pathology. So it's interesting that there are several tests that are described for it, but it's one of those things that you have to have a pretty high index of suspicion for it, and many times you think that there's lunotriquetral pathology, but it might just be normal physiology, or it might be something you're going to treat conservatively also. So mid-carpal instability is also one of those things that's can be very difficult to diagnose. The catch-up clunk is something that is described, but that also can be a difficult, provocative maneuver to perform. And once again, it's really important to compare it to the contralateral side, because someone might be ligamentously lax, and that might just be their normal exam. So you have to compare it to the contralateral side. And then another very important feature, whenever you examine the wrist and you hear clicks or clunks or other various sounds, or someone says, "Oh, my wrist clicks," you have to ask them, is it painful? Is it painful when it clicks? Because there's lots of clicking that occurs in the wrist. Many times when I examine a patient, my wrist clicks, and then they think it's their wrist. And I say, no, it's actually my wrist that's clicking. But if it's not painful, then I'm typically not worried about it. The fovea sign is something that I commonly use for TFCC pathology. I find that to be very useful. Ulnarly loading the wrist and ulnarly deviating it with proto and supination can be very useful for ulno-carpal stress. And then the piano key test can also be useful for looking at DRUJ issues. Imaging, very important, and these are the four commonly used modalities. Radiographs, you start with radiographs. You always start with radiographs, and a key feature with radiographs is you have to get good views. You have to get a good PA, and very importantly, you have to get a good lateral. You have to be incredibly strict with your lateral, and you have to make sure that pisiform is overlapping the distal pole of the scaphoid, because if you don't have a good lateral, you don't really know what you're looking at. You don't know what to compare it to. So when I talk to my residents and my fellows, I tell them that you cannot accept poor radiographs. You have to demand good PAs, and especially a good lateral, because an oblique is not a useful radiograph unless you are specifically looking for the oblique. And the next thing is very helpful just to look at those lines, the proximal line of the proximal row and the proximal line of the distal row, the Galula's lines, and see if they align. If you look at that and you follow those lines, then it's less likely that you'll miss something on the radiograph. MRI is very important. Once again, like I said with radiographs, you have to demand very good radiographs, just like you have to demand good MRIs. And what is a good MRI? You have to ideally demand a 3 Tesla MRI. A 1.5 Tesla is okay many times if there's a dedicated wrist coil that's used for that MRI. And the question is, well, how do you know? What I recommend is that you refer your patients to a advanced imaging location that you know has a 3 Tesla or has a wrist coil and does good wrist MRIs. I don't like my patients going to all sorts of different places for their MRIs. I prefer that they go to places that I know and that I can trust the quality is high. So you want a 3 Tesla. If not, then a 1.5 Tesla with a wrist coil. And you also have to remember, these ligaments are tiny. These ligaments are very small. It's not like the ACL and the knee. So you have to have a very high resolution MRI. The arthrogram that's a topic that people debate. For me, the arthrogram isn't that important if you have a high quality MRI. If you have a low poor quality MRI, like an open MRI, that's many times useless, and so then an arthrogram would be much more helpful. But I don't. And increasingly, I find that a good quality regular MRI without intra-articular contrast isn't commonly necessary. Only special circumstances have I found it necessary. CT scan is less commonly used for me than for MRI. It's when I'm looking for more specific. For instance, looking at the architecture of the sigmoid notch. If there's DRUJ instability, what kind of sigmoid notch do they have? Or, for instance, a hook of the hamate as displayed here, is it something that I can't see on radiographs, or is it a scaphoid non-union that I want to determine preoperatively? What kind of bone graft will I need? How much bone graft will I need? Exactly how much of a humpback deformity do they have? And then ultrasound, finally. Ultrasound is I very seldomly use ultrasound. I think ultrasound is useful when you have a very, very specific question. For instance, you want someone to look at the dorsal scapholunate ligament. So it's when you have a very specific question, when you are looking at a specific tendon pathology, and it's very technician dependent. So once again, you have to send these patients to an ultrasonographer that is a musculoskeletal ultrasonographer that you can trust and that you know does very high quality tests, and then you have to communicate very effectively with them exactly what you're looking for. And then finally, I just included this paper. Now, I don't necessarily agree with this paper, but the point is that examining the wrist can be very challenging. And even with MRI, even with provocative wrist tests, many times the usefulness of it isn't as high as we want it to be. And the question is, well, is it because we're not performing the provocative tests correctly, or are they low-quality MRIs? But I just bring this up as just a reminder that the physical exam coupled with good physical exam coupled with good imaging is essential, and you can't rely on just a good MRI or just a good wrist exam many times. Many times these have to work in conjunction with each other to really find out what's going on. And that's it. Hopefully that was useful.
Thank you, Jacques. I appreciate it. Is this better? Can everybody hear me now?
Yes.
Okay. Awesome. All right. So I think because of the timing, I think we should just go right into Dr. Yang. Dr. Yang is going to speak on wrist arthritis, patterns, progression, and management. You're on, Steve.
All right. Thanks so much, Lou. Again, I'm Stephen Yang. I'm on the faculty of NYU Langone, the Hand Surgery Division. And this next segment of the webinar is going to be on wrist arthritis, patterns, progression, and management. So what distinguishes arthritis of the wrist from arthritis in other parts of the skeleton is that it's more often than not the sequelae of some distant injury or instability. So, for instance, I've listed here some of the most common patterns of arthritis, and we'll start with slack wrist. Slack wrist arthritis is the most common arthritic pattern in the wrist, and as most of you know, results from a scapholunate dissociation with rotatory subluxation of the scaphoid. And the arthritis follows a very predictable pattern of progression, starting at the radial styloid, the radioscaphoid joint, the proximal capitate, and eventually the entire carpus. And I apologize for this X-ray. It got kind of distorted. But the next is snack wrist, and that's scaphoid non-union advanced collapse. And just like the slack wrist, it undergoes an almost identical progression of arthritis. And we'll talk a little bit more about this as the talk goes on. Radiolunate arthritis is a bit of a mystery. It also is the result of scapholunate dissociation, but for reasons that are not entirely clear, the radioscaphoid joint is preserved and the arthritis is restricted to the radiolunate joint. Lunocapitate arthritis is quite rare, but oftentimes seen in conjunction with some scaphotrapezial joint arthritis. Radiocarpal arthritis is most often seen as the end result of articular incongruity following an intra-articular distal radius fracture. It could also be seen as the end stage of Kienbach's disease and carpal collapse. STT arthritis is most often seen in conjunction with basal joint arthritis, but any practicing hand surgeon will start to encounter isolated STT arthritis. DRUJ arthritis is most often idiopathic, but can be the result of injuries as well, affecting the articular congruency of the distal radial ulnar joint. And rheumatoid arthritis, which we will not have the time to discuss in depth. So let's start a little bit with non-operative management. Much in common with the treatment of other joints, we can splint, and I'm going to defer to Olga Hincapie at the end of this webinar to talk a little bit about the therapist's perspective on this. We also treat with non-steroidal anti-inflammatory medication, both oral and now topical. Intra-articular cortisone injections are frequently given. Occupational therapy, again, I'm going to defer to the last talk of the webinar. And it remains to be seen whether viscosupplementation, PRP, or stem cell therapy is going to have a significant role in the treatment of wrist arthritis, and the data are quite limited at this point. I just want to subdivide then the surgical procedures, which I'm going to devote the rest of the talk to, which is total wrist arthrodesis, and then all the motion-sparing procedures, including proximal row carpectomy, scaphoid excision, four-corner fusion, Lunocapitate fusion, radiolunate fusion, radioscapholunate fusion, SCT fusions, and resections. And I'm just going to touch on the arthroplasties. Won't have that much time for that. But it's instructive to start thinking about this by contemplating what the normal range of wrist motion and what we really need for activities of daily living. What Andy Palmer in 1985 taught us was that the range of motion that's necessary for activities of daily living are fairly limited. 5 degrees of flexion, 35 degrees of extension, and 15 degrees of ulnar deviation, and 10 degrees of radial deviation. So not that much. So let's talk a little bit about wrist arthrodesis. Wrist fusions, at least the early techniques, were primarily sliding bone grafts, diamond pins, and rush rods, done specifically for rheumatoid disease. The advent of the modern era of wrist fusion began in the 1970s with Muley's report on the use of a dorsal fixation plate, and about a decade later by Wright and McMurtry when they started using the 3.5 millimeter AO dynamic compression plate. And this is what the current state of the art is for wrist fusions. The most commonly done wrist arthrodesis is with these pre-contoured wrist fusion plates that are specifically designed for this procedure, and they're typically titanium or stainless steel. In the lower left-hand diagram, you can see there's a bit of controversy about which articular surfaces need to be fused, but there's the technique is now fairly commonly agreed upon, and here's some intra-articular photographs and radiographs of a patient of mine undergoing a total wrist arthrodesis. So what do you get from that? Well, wrist fusions do quite well with the standard AO techniques. Fusion rates are almost 100%. Grip strength is about 72% of what would be predicted. Pain relief is excellent. The only problem is that because of the prominence of the plate and tendon irritation, the plate removal rates are as high as 12 to 13%. Hill Hastings did an interesting survey and found that patients who had total wrist fusions were actually more satisfied than the people who had motion-preserving procedures. They were equally willing to have the same procedure again and would have the same procedure sooner. But let's now talk about some of these motion-sparing procedures. The first is the proximal row carpectomy. And on the lower left diagram, you can see the slack wrist progression, and that's what this procedure is most commonly performed for, as well as the snack wrist, the scaphoid non-union advanced collapse. And what characterizes this progression is that the radiolunate articulation is well preserved until the very late stages of disease. The radioscaphoid joint suffers because of the fact that it is more oval in shape, and as you can see from the lower right-hand illustration, it's more like a spoon, and if it's malrotated, there's higher contact stresses and a greater mismatch in the congruency, whereas the radiolunate articulation is more spherical and less inclined to experience those kinds of abnormalities. So as early as 1944, Stam reported his description of proximal row carpectomy, where the scaphoid, the lunate, and the triquetrum are all excised, and what you end up with is a radiocapitate articulation. And what this depends on is a well-preserved proximal capitate joint. It's a simple procedure. You don't worry about non-union because you're not trying to fuse anything. You can mobilize early, no hardware. The only drawbacks are the potential for instability and subluxation, and for that reason, some surgeons will transfix the joint with a K-wire. The other concern is the fact that the radius of curvature of the capitate head is not congruent with the lunate, and it's been found that at 10 years, a third of these joints show evidence of arthritis, but mostly asymptomatic. The outcomes show the motion's quite good, 60 to 70% range of motion. Grip strength is 80 to 90%. But again, in the studies done by Jebsen and also by Dodana, radiographic arthritis at the radiocapitate joint was between 64 to 94%, but again, no correlation with symptoms. I guess we just don't know what happens, though, farther down the road. The other procedure commonly done for slack wrist and snack wrist is scaphoid excision four-corner fusion. And in this procedure, the scaphoid is excised, but the ulnar four bones of the carpus are fused to prevent collapse. And the techniques that are currently used include headless screws, circular plates, and of course, K-wires. And their results are equally good. Grip strength 70 to 80%, range of motion about 50%, and substantial pain relief. Non-union rates are considered very low, but there was a period when the circular plates first were started to be used in the early 2000s. There was some concern about high non-union rates, but subsequent studies, including one by myself and my group, showed a zero rate of non-union. When comparing the proximal row carpectomy and the four-corner fusion, there have been multiple studies, and all of them seem to indicate that there's really no difference in pain relief, grip strength, range of motion. The PRC is simpler and less concerned about non-union, and the PRC might be contraindicated if there is degeneration of the proximal capitate articular surface. It should be known, however, that there have been some trends noted in these studies that show that the proximal row carpectomy has slightly better range of motion, but that the four-corner fusion has slightly better strength. So it might be a consideration when tailoring your treatment to the patient. It's also useful to know that there are other combinations of fusions. So there are scaphoid excisions combined with just a lunocapitate arthrodesis, or just a three-corner fusion with excision of the triquetrum, and two-column fusions, which are becoming somewhat more popular, and they all report good results. So as I mentioned before, lunocapitate arthritis, isolated lunocapitate arthritis, is not common. It's often seen with some scaphotrapezial or STT arthritis. There doesn't seem to be any association with carpal instability, and the reason for this, the etiology, is somewhat unknown, but this is a arthritis pattern that lends itself quite well to lunocapitate fusion. And then there's this entity, which I mentioned early on, which is seen in the setting of scapholunate dissociation, but for some reason, instead of the radioscaphoid joint being affected, the arthritis is isolated to the radiolunate joint, and the etiology is unknown. This was reported by Lou Lane and his group back in 1986, but this is an arthritis pattern that lends itself very well to a radiolunate fusion. And of course, as you can see in this slide, a number of different techniques can be used. Outcomes are very good, 50 to 73% of preoperative range of motion, 50% of grip strength, and significant pain relief, and a low non-union rate. And finally, the radioscapholunate arthritis, again, most commonly seen in the setting of an intra-articular distal radius fracture with incongruity and eventual degeneration. It can also be seen in Kienbach's disease, and there are some cases that are idiopathic. The radioscapholunate arthrodesis, again, many techniques, including the use of nitinol staples, headless screws, and K-wires, and of course there's a specific plate design for this procedure. And for the radioscapholunate arthrodesis, the outcomes also show about 50% range of motion, 70-80% grip strength, and good pain relief. But what's been discovered is that if you do a distal scaphoid resection, you can unlock the midcarpal joint, and this is what McComb showed in his cadaveric study. They showed that with the fusion, the typical arc of motion in a cadaver was 58%, but with the distal scaphoid excision, the motion could be improved to 86%. And later on in 2005, Mark Garcia-Elias demonstrated similar outcomes in a clinical setting. So STT arthritis, again, as I mentioned before, most commonly seen in conjunction with basal joint arthritis of the thumb, but then in some much more rare cases will be seen in isolation. The etiology is unknown. It's oftentimes seen in conjunction with a mild DC deformity. The traditional treatment for it has been STT arthritis, but as I'm going to demonstrate in a couple of slides, others have tried distal scaphoid excision as well as a modified LRTI. Kirk Watson was the one who first described the STT fusion, and he reported good results. But subsequent studies were unable to replicate his good results, and in fact, complication rates were reported at 58%, 52%, non-union rates of 15%, 21%, 25%. So the STT fusion is not as frequently performed these days. The distal scaphoid excision was proposed by Mark Garcia-Elias, and he found that there was an increase in strength. Pain relief was good, but that it resulted in a significant DC deformity. In fact, 57% of his patients developed one. Subsequent studies have also shown severe carpal collapse, and this brings into question what happens to that joint. Typically, we know that DC deformity will result in a slack wrist. So my group reported our results on performing a modified LRTI. That's a complete excision of the trapezium and resection of the proximal 1/4 of the trapezoid, and using the FCR for ligament reconstruction and tendon interposition. What we found was that range of motion improved, grip strength improved, and pain relief was substantial. We had good results. And finally, I'm just going to touch on total wrist arthroplasty. The early designs, which included silicone and the early metallic and polyethylene designs, had problems with durability and high complication rates. These were typically indicated for low-demand patients, elderly women with rheumatoid arthritis. But I do want to leave this talk by mentioning that the fourth-generation designs have now been demonstrating 5-year survival rates about 90 to 97%. We still don't know about the long-term survival, but the results look promising. Thank you very much.
Steve, thank you very much. That was excellent. Great job. One of the listeners typed in a question about DC deformity. And instability, and she was wondering maybe you could explain that a little bit better.
Yeah, so the DC...
Steve, I'm going to go back to that slide right here,
and
then maybe you can explain that.
Yeah, I think if we're talking about the DC deformity in the setting of the distal scaphoid excision, the scaphoid is known to link the proximal and distal rows of the carpus, and so just as in the setting of a scapholunate dissociation and rotatory subluxation of the scaphoid, that instability ultimately then results in degeneration. First, again, at the radial styloid, then the radioscaphoid joint, and through that progression that I've already discussed. So the concern here, of course, is if we're relieving the pain of STT arthritis with the distal scaphoid excision, we are risking long-term degeneration of the remainder of the joint. So again, something to be careful of. I think the question some have asked is really how much scaphoid to take. Maybe taking less scaphoid will result in less carpal instability, but we don't know the answer to that question.
I think your paper demonstrating trapezial excision and then some partial trapezoid excision is great because that eliminates cutting out any of the distal scaphoid.
That's right.
May lead you to getting this painful DC deformity.
That's right.
Maybe you could explain the X-ray here about what makes that X-ray indicate that there's a DC deformity.
Well, it's the lateral view that you want to look at. You can see that the lunate is extended, and the capitate is riding dorsally on the lunate articulation. That sort of zigzag deformity there it looks likely to result in significant degeneration going forward.
All right, great. Thank you very much, Steve. Next, I'm going to speak on TFCC Tears and Ulno-carpal Impaction. Right. So there are myriad causes of wrist pain, and this is a list of some of them, probably not even all of them. So I'm going to speak on the two most common causes, are TFCC tears and Ulno-carpal Impaction, and they are interrelated, and I'll explain how they are interrelated. So people consider ulnar-side of wrist pain the low back pain of hand surgery due to the complex anatomy. And I think this quote for the ulnar side of the wrist is pretty appropriate. Ye shall know the anatomy, and the anatomy shall let you see. And what that means is that there are so many discrete structures in a small area that moving one fingertip width gets you onto a different structure. So it's really important to use your fingertip and palpate carefully and sequentially about the wrist because focal tenderness is really the key to making your diagnosis. So you need to make sure you know where the LT ligament is or the TFC, and I'm going to go over some of this in the future, but the fovea, the DRJ, the ECU tendon, the FCU tendon, all these things are so closely packed that you have to be careful about where you're palpating. So a couple basic osseous structures that we should all know about. One is what ulnar variance means. And ulnar variance is basically the relative length of the ulna and the radius, and it's critical to get your X-ray with the shoulder abducted 90 degrees, the elbow flexed 90 degrees, and then you get a true PA of the wrist. Often X-ray techs can't get that X-ray, so they just kind of lean the forearm in a pronated position, and when the forearm is pronated while you're getting the X-ray, the ulna is relatively too long in pronation, so you're actually going to get a false positive ulnar variance. So when the ulna is longer than the radius, that's an ulnar positive variance. When the ulnar is shorter than the radius, that's an ulnar negative variance. So this is really important because we're going to talk about what we do for ulno-carpal impaction. That gray circle there is the proximal ulnar lunate, and you need to look at that spot every time you look at an x-ray of the wrist because when you see ulno-carpal impaction, the ulnar head bangs into that portion of the lunate, and you can often see cysts there or some even like little fractures or some hyperdensity area right there. So make sure you're looking at that. The arrow is pointing to something called it's the reflection of the hamate at a type 2 lunate, and a type 2 lunate has a second facet which articulates with the hamate, and people who have a type 2 lunate can get some pain and arthritis between the hamate and the lunate. And then the distal radial ulnar joint is pictured there as well. So regarding the anatomy of the TFCC, basically the triangle fibrocartilage complex, or the proper, has two components, and I'm going to show you this on an MRI. But essentially there's a superficial component which attaches to the ulnar styloid tip, and then there's a deep component which is inserts into the base of into the ulnar styloid. When people break their distal radius, often they have an ulnar styloid tip fracture, and therefore only the superficial portion of the TFCC has been torn or incompetent. Rarely, when you have a base of the ulnar styloid fracture, you can get instability of the entire distal radial ulnar joint because both limbs are now in discontinuity, and you can have instability, and you'd actually have to treat that with fixing the ulnar styloid fracture. So Dr. Palmer did a really landmark study and published this in 1984 in Journal of Hand Surgery, and he demonstrated two really important things about ulnar variance and the TFC. One is that there's an inverse relationship between the ulnar variance and the thickness of the TFC. And that just makes sense, because if your ulna is a little bit too long, there's not enough space to have a thick TFC. And if the ulnar is short, meaning you have an ulnar negative variance, then you're probably going to have a thicker TFC. The other important thing he demonstrated was that increasing the positive variance increases the load on the TFC. And this zero here demonstrates what a neutral variance is, where the radius and ulna are exactly level. And in that situation, the ulna sees 18.4% of the load across the wrist. If you shorten the radius just 2 millimeters, 2.5 millimeters, that jumps up the forces on the ulna to 42%. So that's an increase of 24% by just 2.5 millimeters of change. And I'm going to show you what that results in when you have a shortened distal radius after a distal radius fracture. That's coming up in a little bit. I'm going to show you an x-ray of that. So on the examination, Jacques mentioned this earlier, but the real key here for the TFC is the ulnar foveal sign. And the ulnar fovea is just volar to the ulnar styloid, so that US is the ulnar styloid. The ulnar styloid is dorsal on the ulna. And there's a little soft spot just volar to the ulnar styloid, and that's the ulnar fovea. And if you're tender there, then you either have some synovitis or inflammation in the wrist, or you have a TFC sprain or a TFC tear. And out of Mayo Clinic, they demonstrated a 95% sensitivity with that. Just that one examination finding. Ulno-carpal impaction sign is another test that I do essentially in every patient with ulnar-sided wrist pain. The wrist is moved from to maximal ulnar deviation with the forearm pronated, and you place an axial load across the forearm. Essentially what you're trying to do is bang the ulnar head into the lunate, as I was talking about earlier. And that's the way you do it: ulnar deviation, pronation, and axial load. And when patients have pain, that's a positive test, meaning you may have some ulno-carpal impaction. Let's move on to TFC tears. TFC tears are probably the most common cause of ulnar-sided wrist pain. It's often a fall from onto an extended pronated wrist, or I see just as commonly a forceful twisting action, like a power drill that gets clogged and you have a forceful torque to your wrist. Patients complain of a deep aching pain. Sometimes you feel some clicking and popping with pronosupination. Lost my talk. Tyler?
Yeah, it looks like someone pressed the stop sharing. But give me 1 second. I'll bring it back up. Give
Okay.
me about 10 seconds here.
Awesome. Thank you very much. Appreciate it. So to diagnose a TFC tear, essentially it's made on physical examination with that foveal sign, a history consistent with a fall or a torque, and then often I get an MRI. An MRI has a 90 to 95% sensitivity for TFC tears. It's also very helpful for subtle changes in the lunate of ulno-carpal impaction. I'm going to show you some MRIs for this as well. So here's a normal MRI on your upper left, and you can see that there are two clear limbs to the TFC. There's the superficial one into the tip of the ulnar styloid, and there's a deep limb into the base of the ulnar styloid. And those are the two limbs I was talking about. Again, the deeper one that inserts into the base is the critical one for stability. On the bottom right, you can see that there's the TFC, this thickened structure, black structure here, stops before it hits the ulnar styloid. You can also see a little fluid there. That white line there is fluid, and that's fluid between the torn TFC and the ulnar styloid. So that's a TFC tear. Here's what it looks like in arthroscopy. That hole is the TFC tear between the ulnar styloid to the right and then the proper TFC to the left. In surgery, we stick a probe in this little cleft here to kind of pull on the TFC tear. And what we should see in a normal TFC is what we call a trampoline, where we push on the probe and the TFC bounces kind of back up and down, and that's called a trampoline. So a trampoline would be the TFC is intact, meaning it's not torn, and it's bouncing our probe back up and down because it's intact and tight. The treatment of TFC tears, I always try a splint, and Olga can discuss this further in the last lecture. I use a splint, and sometimes they give them a steroid injection into the TFC area. It's been demonstrated that about 60% of patients have resolution of their symptoms within 4 weeks of splinting. If pain persists despite splinting and a steroid injection, then we often discuss surgery. There are so many different surgical options, but here's a typical surgery where there's the TFC tear on the lower left, and there's a needle used passed to the other side of the TFC, and there's a suture brought through it, and then the suture is used to tie the TFC tear down back to itself on the outside of the wrist, and you can see that there's the blue suture there closing the TFC tear. Now, the actual technique is pretty complicated because there's many ways to do this. You can do this open or arthroscopically. You can debride the TFC tear or just fix it. And there's been multiple studies to show there's no difference between open and arthroscopic repair techniques. The one special situation that I have strong opinions about is if the DRJ is unstable, meaning that there's too much looseness between the radius and the ulna, and you have a TFC tear. In that case, you should not obviously debride the TFC. It should be fixed. And in my opinion, you should do an open repair, because when you do the open repair, you also tighten the ligaments of the distal-radial ulnar joint as well as fix a TFCC. It's my opinion that an arthroscopic repair will not stabilize a grossly unstable DRJ without doing some more capsular fixing as well. Let's move on to ulno-carpal impaction. This is typically a different situation. This is usually an insidious onset and pain with repetitive activities. The pain is frequently worse in pronation and ulnar deviation. And again, that ulno-carpal impaction test and the ulnar foveal sign are frequently positive. So the ulno-carpal impaction test is positive because you have the impaction, and the fovea test is positive because often they have a degenerative TFC tear. And I'll show you that. So here's a classic example. Here's a 63-year-old very healthy female who fractured a distal radius 3 years prior to seeing me, and she was never pain-free after she healed. Now, again, this looks subtle, but we know 2.5 millimeters of ulnar positive variance can do for you. You can see how that ulna is 2 to 3 millimeters longer than the radius now. And this is in the perfect position of shoulder abducted 90 degrees, the elbow flexed 90 degrees, and that makes the wrist in neutral position. And back in the old days, we used to get an arthrogram. To the left is the wrist arthrogram. We would inject dye into the wrist joint. And if any dye got into the distal radial ulnar joint, then you knew there was a hole in the TFC because it should only stay in the wrist joint if the TFC was intact. Here's an MRI to the right, and on the MRI you can see there's a dark spot in that special portion of the luna I was telling you about. So the lunate has a dark spot in the ulnar proximal portion of it, and that spot is from the ulnar head banging into it and causing that cartilage change there, cartilage and bony change. So plain radiographs can be normal in the early disease, but remember, if you're suspecting ulnar variance or Ulno-carpal Impaction, you got to make sure you get the good X-ray and measure ulnar variance correctly. MRI, as I showed you, can show cartilage degradation in the lunate and degenerative TFC tears. So treatment involves splints and anti-inflammatories. Often this is a weight-bearing type pain-producing activity, so like push-ups, yoga. If people can avoid that, often this ulno-carpal impaction isn't that painful and they can live with it. I often give them a steroid injection or two because that can calm it down. As we age, we tend to be less active on our wrists, so people who are older can often avoid surgery. That being said, younger patients with a positive ulnar variance and a degenerative TFC tear often need surgery. So what kind of surgeries do we do? There are essentially two ways to think of this. One is if the distal radial ulnar joint is congruent, meaning it's got a good arc of curvature between the radius and the ulnar head, and there's no arthritis, then you basically just shorten the ulna. And that makes sense, right? If the ulna is 3 millimeters too positive, you shorten the ulna. There are two ways to do this. There's an osteotomy in the forearm, or a wafer procedure where we use a scope to kind of debride the ulnar head. And here's a picture of this lady. Here's my patient I showed you earlier. She's about 3 millimeters ulnar positive. I did a forearm ulnar osteotomy. You can see the plate there. I shortened her by 3 millimeters. And on the right here, this is a technique. There are systems that allow us to do this. It's very nice. But you can see here's the cutting guide, and here's the saw. And we say she's 3 millimeters too positive, and we just space this cutting guide 3 millimeters, and we remove a 3 millimeter wedge of bone. We take that wedge of bone out, and then we use this plate and screws to basically shorten the ulna 3 millimeters. And that's what I did in this previous case right there. The other option is doing arthroscopic wafer, where you get a burr, and through the TFC tear, you go in and shave down the ulnar head that's too positive. Now, the concern for this is you have to have a huge TFC tear to get the ulnar head completely out. And sometimes you actually enlarge the TFC tear just doing this operation. So I would not typically do this in a younger person who's more active. The other option would be if the DRJ has arthritis in it or is incongruous, meaning the arc of curvature is not very good. In those cases, you would not do an ulnar shortening osteotomy, but you would do some kind of reconstructive procedure. There are so many of these reconstructive procedures that you could spend a whole hour talking about these. Essentially, I listed the 4 of them here, but they involve either a resection of the ulnar head, a fusion of this radial ulnar joint, or a resection of the entire head, called a Nader procedure. So thank you very much. Let me see. There's one question here from the audience. Which profession or work gives more chances to have a TFC tear? Essentially, anybody who's loading their wrists frequently, weight bearing on them, the power lifters or construction workers or iron workers, people like that who are doing heavy work, increases load across the wrists and will more likely give you a TFC tear. Obviously, if you're ulnar positive, you're going to be more likely to have a degenerative TFC tear just from your ulno-carpal impaction. I think we should move on to the next lecturer, and then we can answer some questions at the end. The next speaker will be Dr. Paksima. talking about common tendinopathies about the wrist.
Okay, thanks, Lou. And I'm going to be talking about tendonitis, and I wanted to put up my disclosures and also thank my some co-authors who helped me with slides and cases. I'm going to talk about four things tonight: decurveinous tendonitis, intersection syndrome, FCR tendonitis, and ECU subluxation or tendinosis. So let's start with talking about decurveinous tendonitis, which is an irritation of the tendons of the first dorsal compartment, the EPB as well as the APL. Here's a cross-section of the anatomy, and what you can see over here, labeled B and C, are your tendons of the first dorsal compartment, and here's a drawing of the same. And essentially, the APL can have between 2 to 4 slips, and the EPB is typically a solitary slip. And there's also a septum that can separate the first dorsal compartment into 2 separate subsheaths. And of those who come to surgery, approximately 62% have a separate subsheath. Now, decurveinous tendonitis, in terms of physical exam, the pain is localized onto the radial side of the wrist and worsens with thumb extension. And the Finkelstein's test is done by asking the patient to place their thumb into their palm, wrap the fingers around the thumb, and then ulnar deviate the wrist. Now, I always make sure that I have the patient do that actively rather than crank down on the wrist, because it's very painful and can really hurt someone by doing a forceful, passive ulnar deviation of their wrist if they have bad decurveinous tendonitis. The differential diagnosis involves intersection syndrome as well as arthritis of the basal joint or the STT joint, because it can hurt in the same area. There is a rare occurring thing which is called triggering decurveins. It happens in about 1% of cases, and when you get significant nodularity of the APL or EPB tendon, you can actually get the locking of the thumb. It can lock an extension. It's very painful and it's kind of impressive. So we just need to be aware of that. The mainstay of treatment for decurveins is non-operative and involves splint immobilization and steroid injection, which is pretty successful. Now, my protocol is I put the patient in a thumb spica splint, and I give them a steroid injection on their initial visit. And what I ask them to do is to lock down the wrist for 3 weeks, and then after 3 weeks of rest, then they start therapy, and later on we're going to hear about the various therapy maneuvers that are available. But that seems to work most of the time for most people. Now, if they come back and they're about 50% better or more, I might give them a second shot. But if they come back and they're not better at all, then they're probably going to be talking about surgery. Surgery involves release of the first dorsal compartment, and the sheath of the first dorsal compartment should be incised along its dorsal aspect, and that's to prevent subluxation. Now, there are anatomic variants, including the separate compartments for the APL and EPB, and we always want to make sure that we've done a complete release when doing the surgery. In terms of the surgical approaches, the superficial branch of the radial nerve is in danger, and it's in the way when doing this approach. And probably the most important part of doing the surgery is preserving and protecting the superficial branches of the radial nerve, getting them up and out of the way so you can get to the first dorsal compartment. Once the compartment has been exposed, then you can incise the sheath. So the transverse incision dotted out here is the skin incision, and then the deeper incision is a longitudinal incision in line with the tendons to release the first dorsal compartment. Complications of treatment for the non-operative side involve mostly those related to splint irritation or steroid injection, and you can get some skin depigmentation, skin irritation, or even fat atrophy or necrosis from the steroids, especially in people with darker skin. You have to have the conversation with them that there's a possibility of skin depigmentation, which leaves quite an unsightly scar. So that's something that can happen. I've seen it happen. On the surgical side, the main complications are associated with injury to the superficial branch of the radial nerve, which needs to be meticulously protected during the dissection. Now, you can also get a subluxation of the APL or the EPB tendon. That's one of the theoretical complications, and so we came up here with an alternative type of a surgery to avoid tendon subluxation, and in this technique, you can actually excise the sheath completely. So instead of just incising it, you excise the sheath, the dorsal and volar components, and the advantage there is that it eliminates the postoperative bump and eliminates the potential for subluxation. So just to go through it real quick, here's a cadaveric dissection showing the first dorsal compartment with the entire rim dorsally and the entire rim volarly excised. And this technique requires no postoperative immobilization, and here's what it looks like. Once it's been completely excised with flexion or extension of the wrist, you get free gliding of the tendon over the area. Now, obviously, this is a cadaveric dissection, not the typical incision that you would use. So we looked at a case series here, 80 wrists over 4 years, and prospectively look for complications such as injury to the radial nerve or need for reoperation, and looked at the outcomes. Notice that 83% of the patients were female, which is pretty common. So the outcomes were that no patients had any recurrences, reoperations, or tendon subluxations. About 8% had persistent pain, 7% had scar tenderness. One patient had superficial radial nerve problems. 3% had a positive Finkelstein's test with continued pain, and the range of motion was quite good. So here's a typical example. You can see here on the slide to your left that there's a large bump. And these are the people where I start thinking about doing the excision rather than the incision for, where there's a real thickening, 5 or 6 millimeters of the first dorsal compartment. And you can see what it looks like postoperatively here. Just a few weeks later, the hair hasn't grown back yet, and the bump is completely gone. On this slide, maybe Tyler can play the video here. You can see the final follow-up with the range of motion of people who've had this surgery with the small transverse incision. Here's a transverse incision. You can see the range of motion. The tendons move freely, and there's no bowstringing. Okay, thank you. Let's go to the next slide, please. Great. And finishing up on that, we're going to move on to intersection syndrome. Now, intersection syndrome is a tendonitis that involves the intersection of the first and second dorsal compartments. And it's got a lot of nicknames. Now, one nickname for this is rower's wrist, because it's seen in this particular type of motion where there's a sort of a rotation of the forearm. And another nickname for it is squeaker's wrist, and this refers to the characteristic and pathognomonic sound that's associated with this problem. And this sound has been described as the sound that your foot would make walking on fresh snow, sort of a crunchiness that happens with intersection syndrome. The typical location is a little more proximal than Decorave's tendonitis, so it's a little more up the forearm, and the main treatment for this is non-operative. And non-operative treatment is usually successful, involves thumb spike splinting again, and anti-inflammatories, avoiding the exacerbating activity, the rowing or the rotation of the forearm and wrist, and steroid injections in refractory cases. Rarely is surgery indicated, but when it is, it's quite successful and involves an incision more proximal than you would normally make for a Decorave's, and a release of the intersection of the first and second compartments with a tenosynovectomy. Bowstringing is not a problem in this particular surgery, and there's no need to reconstruct the tendon sheath. Moving on to FCR tendonitis, another common tendonitis that we see in the wrist. Now, the FCR starts off in the flexor pronator mass, but its insertion is a little bit of a mystery. Most people think that the FCR sort of ends at the distal palmar crease, but there's another 1.5 inches of tendon that goes on distally. So the FCR actually inserts onto the index metacarpal and doesn't end at the wrist crease. And that 1.5 inches of tendon is referred to as the forgotten tendon. And that's where FCR tendonitis occurs. The FCR actually has 5 points of insertion, the index metacarpal being the main one, but also it touches onto the trapezium, the trapezoid, the scaphoid, as well as the middle finger metacarpal. And in that, if anyone's done a basal joint arthroplasty, once you resect the trapezium, you can see the FCR tendon running through that empty hole, and that's the part of the tendon that becomes inflamed. So the theory is that FCR takes a sharp turn there as it crosses the ridge of the trapezium, and it goes into this tight fibrous tunnel. Now, the FCR takes up about 90% of the space in that area, so a little bit of tendonitis, a little bit of inflammation, doesn't leave a lot of space, and it causes quite a bit of pain. The pain is felt with resisted wrist flexion and radial deviation. The differential for this condition is decurrence tendonitis, scaphoid fractures are non-union, basal joint arthritis, and ganglion cysts. Ganglion cysts are quite common in this area and can often be associated with the FCR tendon sheath. So whenever you're looking at a volar wrist ganglion, one of the potential sites could be coming from FCR. Non-operative treatment is splinting, rest, and ice, and in the usual way, the steroid injection should be directed distally. And you can see here the steroid injection is directed distally into the fibroosseous sheath. Operative management is, again, rare and usually does not required, but when it is, involves release and tenosynovectomy of the tendon in that distal portion. In danger is the palmar-cutaneous branch of the median nerve, which should be protected. And lastly, we're going to talk about ECU tendonitis and ECU subluxation. Now, the ECU has a unique anatomy of the extensor tendons, where if you have the extensor retinaculum that forms the 6 compartments, but there's a separate subsheath that keeps the ECU in its fibroosseous tunnel riding along the dorsal aspect of the ulna. And it's disruption of this fibroosseous tunnel which leads to symptoms. The pathogenesis is active ECU contraction with forced supination, palmar flexion, and ulnar deviation, typically seen in racket sports, here in baseball or golf. And the natural history is of a painful snapping tendon with forearm rotation, and this can be associated with or without additional tendonitis. The DREJ can be affected because the ECU is a dynamic stabilizer, and there's a wide range of symptoms. Some patients are minimally symptomatic and improve without any intervention, and some require surgery. How do we assess it? Plain films always, as Dr. Hacquebord pointed out, are our best friend along with history, but sometimes an MRI is required, and my favorite is an ultrasound for this particular problem because it's a dynamic study. You can actually see the tendon snapping in and out, and it helps identify the pathology. The subsheath tear has been classified. We like to classify things in orthopedics, so we have ulnar-sided tears, radial-sided tears, those associated with dislocation of the tendon, and those where a pseudopouch is formed from basically a patulous fibroosseous tunnel. A non-operative management can be divided into 3 phases. So our first phase is the immobilization phase, and it takes about 2 weeks. So either long arm or short arm, depending on the degree of symptoms, long arm or short arm splinting, and this goes on for about 2 weeks. Next, the second phase is the motion recovery phase, and this involves coming out of the splint 3 to 5 times a day with the ECU taped for motion, and that goes on for another 2 to 3 weeks. So that's a total of 4 weeks of splinting, with the second 2 weeks you're coming out of the splint and doing range of motion activity exercises. And then the final phase is the strength recovery phase with specific sports training, and that can last from 2 weeks or to longer to get the patient back to activity. Operative management really depends on the degree of symptoms. Sometimes we do these acutely, and especially in those that present late and have sort of missed their chance at splinting, and those unresponsive to non-operative treatment. There's lots of different techniques, probably a dozen or so when I was looking for this talk, but they all involve the similar concept. The concept is to put the ECU back dorsally and keep it in its sheath. So some type of a sling using a retinaculum is the most common, and I like this radially based sling. It's an easy technique to do. You just go in under and around and back onto itself, and it stabilizes the ECU very nicely. There's alternatives. You can make a fibroosseous groove and deepening techniques, and as well as those involving suture anchors and retinacular flaps or grafts. Postoperatively, the elbow should be immobilized. You want above elbow immobilization to minimize supination and pronation, and you can use a Munster splint if necessary so that you don't get a stiff elbow. And the sutures are removed at 2 weeks, but the long arm immobilization goes on for 4 weeks, followed by short arm immobilization for 2 weeks. For 4 weeks. Okay, I'm going to stop here, and thank you for your attention. I just wanted to answer some of the questions here in the audience. And I see that someone asked for the steroid injection, do you generally go over the maximal point of tenderness or use anatomic landmarks? I usually use anatomic landmarks and try to get into the first dorsal compartment, although even if you miss and are in the neighborhood, that's usually okay. And the skin depigmentation can show up quickly, and it may never resolve. So just be aware of that. So let me stop here and make sure we have enough time for our final speaker, and I'll be happy to answer any more questions at the end. Thank you.
Thank you very much, Nader. That was great. I have a question for you about the ECU instability. I often find it pretty difficult to compare side to side to confirm the diagnosis of some ECU instability. Do you ever get any dynamic ultrasounds or any other additional studies to confirm your diagnosis?
Yeah, exactly. That's my favorite go-to study, the dynamic ultrasound, and I find that's very useful. And I'm lucky we have an ultrasound machine here where I can do it myself, but otherwise our radiologists are very good about identifying the ECU, and you can really see it snap in and out on an ultrasound to confirm the diagnosis.
All right, great. Thank you very much. Our last speaker is Olga Hincapie, and she's going to talk on hand therapy interventions for wrist pain.
Thank you, Dr. Catalano. My presentation is an overview of the hand therapy interventions in wrist pain. I divided my presentation in 3 topics. The first one is wrist tendinopathies, the second one, wrist ligament injuries, and finally, wrist arthritis. I just hope my presentation can be uploaded.
And just an announcement to everyone. It looks like the presentation accidentally got dropped off. It's just being reloaded now. It should take another 10 to 15 seconds, and it should be back up. And again, I apologize for the inconvenience. We should be back up and running here in a few moments.
We can maybe go over.
While that's coming up, I was going to say there was a question about how long do you mobilize after TFC repair. Generally, if I'm doing a repair for unstable DRUJ, I'll immobilize for 6 weeks in a long arm splint. I'd love to hear the other thoughts from the rest of the panel.
Nader, could you hear me?
Yes.
Yeah, I would agree with you. 6 weeks in a sugar tongue. Now, that being said, the number one, they don't get stiff very often. Number two, I don't fix many TFC tears unless the DRJ is unstable. We can talk about the indications for that later. So, Olga, you're on, and hopefully your slides are working now.
Thank you. Okay, so Dr. Paksima went over the wrist tendinopathies. I just have this slide to show the most common ones. ECU tenosynovitis, I just put it in a square because it can be also a source of wrist, ulnar-sided wrist pain, and on the volar side we have the FCR and the FCU tendonitis. He went over this, so I'm not going to repeat anything about this. The assessment begins with a thorough history, including provocative activities and associated medical conditions that can predispose the patient to a tendinopathy. Pain is usually localized and increases with pressure, stretch, or resistance to the affected tendons. In an acute stage, we may have redness and swelling, and in a chronic, we can have crepitus. Some of the objective measurements that we use are range of motion, grip strength, and pinch strength. And as outcome measures, we use usually the quick dash and the patient-rated wrist evaluation. The general principles of management for wrist tendinopathies are first, the reduction of pain and inflammation. Second, the enhancement of tendon healing and mobility. Then, when the symptoms subside, we can progress to strengthening. And finally, the return to previous level of activity and lifestyle modification. So I'm going to go over each one of these. So Dr. Paksima mentioned the cortisone injection, and rest is important for that tendon that is pain and swollen. So we use static orthosis and rigid orthosis in the acute phase, and as the patient is progressing, they can be transferred to semi-flexible or more softer orthosis. In addition, we have modalities as cryotherapy, thermotherapy, iontophoresis, and laser therapy. And from all these modalities is laser therapy that has a little more research backing it up. So that's a thing to consider for our patients. For the enhancement of tendon healing and mobility, we have instrument-assisted soft tissue mobilization techniques like Graston in the left or A-stim in the picture on the right. These techniques use instruments that help with scar remodeling, and also they facilitate healing process through formation of new collagen fibers. In addition to the soft tissue mobilization, we need to include gliding and stretching of the tendons. We know that when the length of a muscle or tendon unit is increased, strain during joint movement is decreased. So gliding should be performed in a gentle and pain-free manner. When the symptoms subside, the pain, the swelling, we can start with progressive strengthening. When the strengthening is performed in a graded and symptom-free manner, we can help with speed repair, and also we can have the patient prepared to meet the physical demands of the daily activities. We usually start with isometric exercises at mid-range, progressing to isotonic that can be concentric or eccentric. There's a lot of research backing up eccentric exercise for chronic tendinopathies, and finally the isokinetic exercises. Finally, we have the return to previous level activity and lifestyle modifications. Patients are recommended to resume the activities gradually and in a pain-free manner. We may have some step backs during the treatment, so they need to know that they may need to wear the splint again, or stop some activities, or decrease the amount of repetition for the exercises. In addition to that, ergonomic modifications are necessary for these patients, and some general guidelines are, for example, postural considerations, balance, rest and activity, organize and arrange space, stop activities or parts of them, and reduce the amount of weight that patients take through the joints. Some equipment that can save energy, adaptive equipment, is necessary, and because there's a great population of patients that can have tendinopathies. People that work in the computer may need all the ergonomic adaptations. Musicians are another patient population that may need assistive equipment or instructions about technique, posture, and finally the mummies, the new mummies that develop decurvent tendonitis, they may need some indications to use their wrist in neutral and have some adaptive equipment. Now, the second topic that I'm going to speak about is wrist pain secondary to ligament injuries. In a very simplified way, we can say that in the radial side we can have the most common scapholunate ligament injury, and in the ulnar side the TFCC. When we don't have referrals from hand surgeons, we frequently get the diagnosis of wrist sprain. So it is important for the therapist to do a good palpation, as Dr. Hacquebord said, get a good history. In the last 15 years, we have learned a lot about wrist ligaments, and we know now that they are more than mechanical restraint. They have more than a mechanical function. They have a sensory function, specifically a proprioceptive function. So we know that the scapholunate ligament has a lot of mechanoreceptors, and the TFCC, especially the palmar radio-ulnar ligament and the dorsal radio-ulnar ligament, are more than they have more than a mechanical function, and they have a proprioceptive function. So based on that, it's important for the therapist to remember the basic concepts of sensory motor control, and know that proprioception is a subcomponent of that sensory motor system control. And proprioception involves the sense of kinesthesia, joint position sense, and the neuromuscular sense. All these things can be affected after a ligament injury. Our evaluation starts with evaluating pain. We usually use the subcomponent scale of the patient-rated wrist evaluation, because that gives us information about the pain when patient is bearing weight on the wrist, when he's doing certain activities of the daily living, range of motion, grip strength, joint position sense. The capability of weight bearing that we can do using the dynamometer is called the push-off test. You can see it in the bottom right. And the functional assessment using the quick dash and the patient-rated wrist evaluation. Dr. Elizabeth Hager in 2010 provide us with the guidelines or the rehabilitation plan for proprioception rehabilitation in patients with wrist ligament injuries. She developed that plan in 6 stages. The stage 1 is like basic rehabilitation, edema control, pain control, and range of motion. The stage 2 includes proprioception awareness. Stage 3, joint position sense, kinesthesia, and the elements of conscious neuromuscular rehabilitation and unconscious neuromuscular rehabilitation. Over the years, some other authors have worked on this rehabilitation plan. In an early phase, in general, this is general for right-sided and ulnar-sided, we can have splints, thumb spicas, wrist brace, ulnar cutters, and sometimes when we have injuries of the ECU or the TFCC, we need to go above the elbow and preventing rotation of the forearm. In the early phases, it is important to improve that conscious sense, and we can use mirror therapy for proprioception awareness. We can do joint position sense retraining, as you can see in the picture in the above right, upright, and kinesthetic re-education. We can use a simple laser pointer to create paths of motion, protected motion. In the case of the scapholunate ligament, we're going to work in a physiologic wrist motion, that is the dart throwing motion, from radial and from extension and radial deviation to flexion and ulnar deviation. It is important to know what are the muscles that are going to help stabilize the joints, the scapholunate joint or the TFCC. So we know that for the scapholunate ligament injury, the friendly muscles, the stabilizers, are going to be the extensor carpi radialis longus, APL, FCU, and FCR. So we can start with some isometric training of those muscles. For the TFCC, we know that we need to strengthen the ECU and the pronator quadratus because they help with distal radio-ulnar joint stability. In an intermediate phase, we're going to start a progressive loading. So we're going to combine control motion in a dart throwing motion pattern with progressive load. The patient's response is the one that is going to dictate the progression. Increased pain means that we need to have a step back. In the cases of ulnar-sided pain and a positive ulnar variance, we have to take into account that the ulnar variance changes with forearm rotation. So a combination of pronation and gripping increase the load on ulnar-sided structures. So that is important. In the late phase, we're going to improve the neuromuscular control. So we're gonna work with oscillatory devices. We're going to promote reactive muscle activation, and we're going to start loading more the wrist. We're going to start with axial loading, and then we're going to progress to the same axial loading on unstable surfaces, and we can add perturbations. Patients want to go back to previous level of activity. There's a recent study published in the Journal of Hand Therapy in 2018 that speaks about the distribution of forces with the wrist in hyperextension, especially when people do push-ups, or with the wrist in neutral. And the conclusion of the study is that in neutral, there's a better distribution of forces because with wrist in hyperextension is mostly the ulnar side of the wrist, which is loaded. Finally, I have only one slide for hand therapy in wrist arthritis. There's not much evidence about therapy for wrist arthritis. The evidence for osteoarthritis is big for the thumb, for the base of the thumb. But for wrist arthritis, there is not much. I would say that our intervention is a combination of orthosis, manual therapy, and exercise. And when I say exercise, I'm not saying range of motion exercise. I'm saying isometric exercises at mid-range because we don't want to aggravate the pain, and we are not looking for full active range of motion. And another important component is the joint protection for those patients and the activity modification. So this is it. Thank you very much.
Thank you, Olga. We have maybe a couple questions here. Dr. Paksima, someone asked, how often do you see distal intersection syndrome?
You know, that's a good question. I don't think I've ever seen it, although any of these tendons can certainly rub over each other. The question was APL over the second compartment, and I have not found that to be a problem. Now, you can get isolated EPL tendonitis, and maybe that's what it was, and I missed it, but the treatment, I would say the treatment is essentially the same: splinting, rest, injection, and then debridement if it doesn't respond.
This is unbelievable, but this is the first time in my life, in 19 years, I've operated on it was today.
Is that right?
Yes. The lady had severe tenosynovitis of both and had failed non-operative measures. And I did a tenosynovectomy of both the second and third compartment and actually repaired a portion of RPL because it was pretty beat up. So,
okay.
Funny he asked that today, and I've never done that until this morning. Olga, I have a question for you. Are there things that like wrist pain that comes to you that you think, oh, geez, this is a really complicated thing. I don't know if I can make it better. And there are things that you see that you say, geez, this is good. I'm really going to hit home run with my therapy.
Let me think. I always like to give it a chance to conservative treatment, but I don't know what you mean with a bad wrist.
No, meaning certain diseases that you think you can really treat effectively with therapy, and others that you are more pessimistic about your methods.
Like wrist arthritis, I don't think we can. At the end, the patient is going to have surgery, so I don't think it's very optimistic. We give them, if they don't want to go for surgery, we offer splinting, we offer activity modification, and that's it, and maybe isometrics. But we know that is a patient that is going to end up in surgery. Surprisingly, wrist ligament injuries, and we have seen them, quite a few of them, like partial ligament tears, partial scapholunate ligament tears, some of the TFCC injuries. We have good results, including these proprioceptive techniques.
Great. Dr. Yang, do you have any questions or
I don't,
comments?
but I see that there's a couple of questions here. We do have just about a minute or two. Olga, I see a question here about ideas for inflammation and DRUJ palpated pain and post-distal radius fracture, also following ROH, limiting active wrist extension beyond mid-range. Do you have any comments for that?
Can you say that again, Dr. Yang?
Yeah, it's. I see here a question. Any ideas for inflammation in DRUJ palpated pain and post-distal radius fracture? Yeah.
You know, I'm just Paksima, just jumping in. You know, I mean, I tell all my patients with a distal radius fracture that the radius is going to heal and not give them a problem, but they're going to have ulnar-sided wrist pain. And you know, we know that about 100% of the time there's some injury to the TFC, and there may be some subtle injuries to the DRUJ that can cause persistent pain. So for those people, I try a cortisone injection into the area. And then if that doesn't work, try to find some specific reason why their DRUJ is hurting. Is it post-traumatic arthritis? Is there a TFC tear that hasn't settled down that needs to be debrided or something? But there's a reason why it hurts, and it's very common.
I think that's exactly right. Unfortunately, it looks like we've run out of time. It's exactly 9:30 now, and I'd like to just take this opportunity to thank our speakers, Jacques Hacquebord, Nader Paksima, Lou Catalano, and Olga Hincapie. And I also want to thank all of you who participated as listeners tonight. We hope you got something out of this webinar and learned something about wrist pain. Thank you very much.
Thank you.
Thank you.
Great. Thank you so much, everyone. And on behalf of NYU School of Medicine, I'd like to thank all of you for your participation in today's event. Please feel free to download the course presentations in your handout section. You will now be redirected to the CME login page. Please log in and take a moment to complete the appropriate course evaluation and attest to your credits to obtain your certificate. This concludes today's program. Thank you, and have a great day.